In the past presentations, you've emphasized that clinicians must prevent bad things from happening, specifically strokes. What are your recommendations for clinicians to achieve this?
Well, there's a lot of things that people can think about. It's human nature to worry about causing something bad, and less so they're worrying about preventing something bad. And in fact, studies have shown that generally, as human beings, we tend to overestimate rare risk and underestimate common risk. And so what we're trying to do is correct that balance here. When Coumadin first was looked at with respect to stroke prevention, it turned out for probably about every 10 strokes we prevented, we caused 1 bleed. And with the new anticoagulants that are out, we're actually making those numbers even better. We're preventing more strokes, and yet we're not causing more bleeds often, we're preventing more bleeds. And the thing about stroke in atrial fibrillation is it's devastating. When you think about the clot burden, it's probably as big as the tip of your finger, like 1 distal phalanx. And so that's a lot of clot that can cause a lot of damage to the brain. And that's why these strokes tend to be either about 1/3 die, 1/3 are disabled, and it gives you about a 1 in 3 chance you'll get through a stroke relatively unscathed. Whereas the bleeds, we can usually get people through quite easily. That's not to minimize how serious those are, but if people are worried about the bleeds, remember, we can get most of those through okay. The strokes, the damage is generally done, and remember that the balance is that there's many more strokes to prevent than there are bleeds that we will cause.